Thank you. Okay. So next slide is, again, just looking at supportive housing. Again, a lot of supportive housing came in trying to serve people that we now would call chronically homeless, people who've been homeless for a very long time, a year or more often, or 4 episodes in 3 years, and people who have a disability. For the homeless piece, you need the affordable piece. For the disability piece, and often in order to maintain services, you need the supportive piece. So supportive housing is the answer. But it's also being used in a variety of projects across the country to help individuals leave institutions and live in the community, again, following the federal Olmstead decrees. It's working for families, child welfare-involved families, youth people. It's an opportunity for people exiting jails or prisons with chronic health conditions, particularly people with mental health challenges. And then, again, it's used for people with behavioral health conditions who have both the disabling condition as well as the housing need. And just go from there. Just thank you. Next slide. So we are at the a little more than a year anniversary for when the Center for Medicaid Services, Center for Medicare and Medicaid Services, offered what's called an information bulletin. This is one of their main methods for communicating with the states in regard to what it is they're looking to serve, what it is they're looking to do with Medicaid related. So this is really some of the most focused assistance we've gotten from, our friends at the Interagency Council on Homelessness, at the Federal Housing and Urban Development, have been working for years to get the Center for Medicaid Services to this point. So this is a letter, certainly happy to share a copy with anyone who could use it, that tells state Medicaid offices, we think supportive housing is important, and here's what within supportive housing CMS can look to cover from a services perspective, and here's what we can't cover. And so this is very important information and something that a lot of state Medicaid offices are looking at very closely. What's important to remember about Medicaid is that it's a mix of federal and state funding. So CMS in here is saying, here's some things you can't do. It can't force anyone to do it. It can't require anyone to do it. It says to states, here are some options. Usually these things are often called guidance because you're telling people what the options are. I'm going to move on to the next one. So this gives states the options. Doesn't mean they have to. Just means they can. So a services crosswalk is what we did. We looked at a couple of things. We looked at our Pennsylvania State Medicaid plan. We looked at what Medicaid waivers are that Pennsylvania has looked at. Medicaid waivers are agreements between the state and the federal government saying, we'd like to do things maybe a little bit differently. Federal Medicaid has requirements. These are the things you must do. And then the states have a great deal of flexibility. Much of that flexibility is talked about in regard to the waivers. And then there's a second possibility of how we compare that in regard to how our managed care organizations, what used to be called HMOs, what services they cover. There are services that they are required to cover by the state plan, and then there are also supplemental services. They can have a conversation with the state saying, we want to do A, it's not required, but we think we can do this with our funding, and there's a conversation that happens, and hopefully the state and the MCO can come to some level of agreement there. So that's a lot of how that works. And so part of what we also do in the crosswalk is we interview the supportive services providers, and we ask them, and supportive housing providers, and we say, do you offer case management? Are you being funded by your Medicaid plan for case management? What are the services covered? Do you know who in your supportive housing is Medicaid eligible and who isn't? And are they not eligible? Well, let me make a distinction between eligible, meaning you could be enrolled, and then people who are actually enrolled. And it's a lot of work and a lot of engagement for providers to even, supportive housing providers to even understand, are their resident Medicaid enrolled? Very, very important. An MCO can't provide services or can't fund services, can't fund another provider to do the services unless the individual's enrolled. And then the provider talks about what they saw as the gaps, and then what they saw as the coverage. And then we compared that to the state plan. So these are the findings. There are ways currently to bill for supportive housing services, but there are limitations on that, and we want to highlight what the limitations are. Most commonly, this is something I know we've been doing in Philadelphia for over a decade, we've used targeted case management Pennsylvania has targeted case management under our services for people with serious mental illness. This provides the most comprehensive alignment. So if you have an individual with a diagnosis of serious mental illness, if that person qualifies for case management, then that person may be eligible for the supportive services portion of supportive housing. So that's really an option. But there are big ifs there I talked about. There are ifs in regard to the population, folks with SMI. There are ifs in regard to what the services are and how you do that. A lot of the devil's in the details on this. Here we talked about populations. Pre-tenancy services, the services that allow people to attain housing, could be done by case management if it's part of a service plan. Tenancy support services, also an option if they are part of a service plan. But here's the issue. If you are the supportive housing provider and they already have targeted case management services, it's that targeted case management service that's funded for these pre-tenancy or some of these tenancy supports. So there's a lot of detail in this, a lot of nuance, and a lot of real confusion that I think providers can find in regard to what they're able to do and what they're able to bill for. The other piece that I really want to highlight is the significant number of populations not served. The largest percentage of populations not served are individuals with substance use disorders. So if you can get a diagnosis of serious mental illness, then you have some options and opportunities. If you can't get a diagnosis of serious mental illness, then you're really out of luck in regard to targeted case management for most communities across the state. And now, I do know that, again, my detailed knowledge of Philadelphia says that we do have a small pilot project in regard to case management for folks with drug and alcohol challenges, but that's very, very novel, both within Pennsylvania as well as broader. And it's also very small because when something's not an entitlement service, you may have a small targeted population for it. So just another piece there. So we're not being served. And then there's nuances and real challenges for providers if they want to do the tenancy support services. Highlight and start mainly with the recommendations. First recommendation is for the coalition to work with the state in regard to define and cover supportive housing services using the CMS guidelines from June, the June informational bulletin. I want to point out that it's been, my understanding is a significant amount of time, maybe over 10, 15 years, since there's really been a really detailed relook at the state Medicaid plan. And there's really a lot of been changes since then. This might be an opportunity for the state to look closely at that plan, not just about supportive housing services, but other evidence-based practices, and how that plan really needs to be reconsidered in light of current guidance and guidelines from CMS, certainly in light of the ACA and other opportunities we have there. Two, very much highlight, again, the population. When we talk to homeless providers, shelter providers, when we talk to supportive housing providers, we found that they had a much harder time getting supportive services and case management services for individuals with substance use disorders. There's a lot of going on of them constantly trying to find the mental health challenge. Maybe it's there, maybe it's not. Maybe it's hard to find underneath all of that substance use, et cetera. But a lot of times providers spend trying to stretch that definition because what they're really trying to do is fit the services. If supportive services and supportive housing services and case management was included in our state plan for individuals with substance use disorders, there'd be a much broader opportunity there. That's our second recommendation. Our third recommendation is to what we call build capacity in the Medicaid delivery system to understand supportive housing. This is looking at, and these 3 and 4 are really highlighted. Medicaid is extremely complicated. In Pennsylvania, you need to be licensed as a provider. You need to be, which is done by the state, a provider for a particular service. There's a significant amount of requirements. People have to be in certain jobs with certain educational backgrounds, certain experience, things of that nature. There's also becoming in-network as a provider for your community's managed care organization. Some networks are open, some networks are closed, some networks are willing to have some kind of dialogue if you bring something unique to the table. Supportive housing is definitely something unique. So we really need to bring and explain and help the Medicaid system and the MCOs better understand supportive housing, better understand what we call a whole person model of care, meaning looking not just at the medical model, but looking at a whole person first considered services. Let's go. people. And then build capacity into the whole system, build capacity for the whole person system of care by promoting training and technical assistance for supportive housing providers to build Medicaid. As you may have been doing services for decades, but it is a very heavy lift. I work with Project Home in particular on this and other providers. It's a very heavy lift to determine how you're going to bill Medicaid, to determine what your services are called under a Medicaid framework, to determine your data systems. The data systems that most supportive housing providers are using often are not capable of what we call dropping a clean claim to a Medicaid managed care organization. Therefore, they're going to need training and support in regard to that. So there's a lot of support that needs to be done for the supportive housing system in order to join Medicaid and become part of a Medicaid system. And then finally, what the expectation is also is that there will be cost savings related to getting people in supportive housing. So the expectation is that, and hope is that we would able to redirect some of those cost savings back to what are called our county housing plans. So each of the counties has behavioral health system, has the opportunity with the State Office of Mental Health and Substance Abuse Services to have a county housing plan to redirect some of those cost savings back to the county housing plans. So our final recommendation is, as we get more people into supported housing, as we recognize cost savings, highlight where those cost savings are going and recommend that they go back into county housing plans. So I believe with that, we can either take questions or keep moving. Joyce, Patrick, I'm turning it back over to you all.
I think our goal is to keep moving.
Okay. Cool.
Monica?
Great. Okay, can you hear me?
Yes.
Okay, thanks. Hi, everybody. I'm really excited to be virtually with you all. I'm also really excited to see how many people have joined the call, so I hope this is informative. My contact information, I believe, is at the end if you need to talk offline about any of the stuff that any of us talk about. So I'm calling from Project Home based in Philadelphia. Oops, I'm advancing. Here we go. Wait a second. My slide. There it goes. Okay, great. So our mission in Philadelphia is to end and prevent homelessness, and we do this through a variety of strategies. We address the social determinants of homelessness and poverty through street outreach, housing, education. We have social enterprises, a lot of supported employment and competitive employment opportunities. Healthcare, which is in my wheelhouse, and neighborhood development. And our co-founders about 26 years ago are Sister Mary Scullion and Joan McConnon. You can check out our website for more info. So my area is really in the healthcare side of the organization, and specifically we have a couple of healthcare initiatives within Project Home, and the part that I'm more directly involved with is at our federally qualified health center, which is the Stephen Klein Wellness Center in North Philadelphia. This is a list of all the services that we provide. We're pretty new to the arena of healthcare. We ran a small free clinic for about 18 years before, which didn't involve any billing whatsoever. We basically operated on grants, and we're just joined the wonderful world of billing, at least on the FQHC side, in 2013. And I will talk about the other healthcare initiative that Project Home does called Psych Rehab Services, which we started I think a year or two before we became an FQHC, and I'll explain a little bit about that. But we're I guess what a lot of community health centers are in Pennsylvania. We offer primary care with embedded behavioral health care, working alongside the primary care providers. We have a dental practice. We just opened a pharmacy and a list, and there's the list of all the other services that we provide. And our target populations are both people who are experiencing homelessness, who are literally street or shelter homeless, and also people who are unstably housed, precariously housed, transitionally housed, living in North Philadelphia. The vast majority of the folks that we serve are low income to very low income. So a little bit about supportive housing, which I probably don't need to go into considering the audience for today, but that's just sort of some, and also Marcella described it very, very well, so I won't really go into that too much. I'm going to kind of move on. And so how we see healthcare integrated with Project Home, on the FQHC side, we really try to promote this idea of person-centered health home. So we really try to incorporate the goals of the people that we're serving, to not be too paternalistic in how we approach healthcare, and make sure that we're assessing and determining what each individual or each family's goal is in determining a treatment plan. And we try to be comprehensive, so we try to incorporate a whole, like a one-stop shop in our facility, and we try to promote also open access. So one of our practices here is we do same day or next day only appointments, which has greatly reduced our no-show rate and has enabled us to really serve a lot more people. I think some of the best ways to describe the importance of integrating supportive housing with healthcare, sort of from the healthcare provider side. So I'm really speaking now as I'm a physician assistant, so I take care of patients and their chronic conditions, both medically and also I take care of sometimes folks' behavioral health conditions as well, is the oftentimes the missing link in helping people manage their chronic illnesses is housing that is stable, that is affordable, that is available. So just to give you a couple of examples of patients I've encountered, Richard, not his real name, is a gentleman that I took care of for a couple of years while he was street homeless. He had both behavioral health, mental health issues, as well as some pretty serious medical issues. What he needed was a platform, a safe place to address these issues, and for a couple of years that was inaccessible. Finally, through a lot of efforts through our outreach teams and case management teams through Project Home, we were able to connect him to supportive housing, and we were remain connected to him as his primary care provider. He was able to deal with his chronic medical conditions, specifically his hernia, which got so severe that he could really not even walk with that condition. He became incontinent as a result of that condition. It further worsened his depression, further worsened his alcohol use. But because supportive housing was now available to him, we were able to take care of his medical issues a lot better. He had probably visited the emergency room while he was on the street at least maybe 5 times in the year that I knew him. And then since he had gotten the surgery and gotten some of his medical issues taken care of, his alcohol intake actually went down to near zero. He said he used to drink alcohol to kind of cope with the life stressors that he was under and the depression that he's experiencing living on the street. And so he said his alcohol use went way down, and he had not gone to the hospital in the years since he entered housing. So he's kind of a very good example of the importance of, healthcare can only go so far. Traditional healthcare can only go so far. Housing needs to be a part of the mix. Janice is another example of a person who was street homeless. Serious mental illness, also I didn't mention here, but also history of dual diagnosis substance use, on top of that trauma, and needing a psychiatric evaluation to qualify for supportive housing. So our role was really to partner with the supportive housing side of Project Home to get her quick access to the psychiatric evaluations that she needed through our health center. Another example, which I actually don't have listed here, but I'll talk real briefly, is a gentleman who was in shelter for a couple of who went into shelter after leaving jail. He was in jail for I think about 5 years. Serious diabetic, was actually wheelchair bound because he was a partial amputee, also partially blind from his diabetes. And unfortunately, his story wasn't as good of an outcome as the first gentleman I mentioned, in that we had a real difficult time getting him into any kind of supportive housing. And he unfortunately perished as a result, I think, is a direct result of him not being able to access housing because we weren't able to really help him control a lot of his medical issues. In the shelter system, as I'm sure many of you know, it's really difficult to manage serious health conditions, to make appointments, to take your medication regularly, to really focus on your health while you're focusing really on just sort of basic survival in the shelter. So unfortunately, his case was, I always think of him when I think of the importance of supportive housing and promoting a person's overall wellness and being able to deal with their chronic health conditions. The next slide I want to talk about is a little bit about our experience in entering the world of medical assistance and becoming a medical assistance provider in addition to being a supportive housing provider. I did forget to mention that Project Home has about 700 units of supportive housing throughout the city, and that's really how we originated. Healthcare is a really, really new area for us. But our first entree into becoming a healthcare provider is when we became licensed as a psychiatric rehab services provider. And what this basically is, and I can give a little bit of a definition here, is we actually gave it a different term, and just for kind of put a different spin on it a little bit, is we call it PRS, or Personal Recovery Services, instead of Psychiatric Rehab Services. And it's our version of PRS. It's person-centered, evidence-based practice that is getting a lot of increasing credibility in the behavioral health field. And the model is that it's a mobile team of specially trained team members to travel to all of our Project Home sites, and they work one-on-one with eligible individuals to request services, and they try to help ascertain each individual's goals and help them and coach them to work towards those goals. So they'll work on things like life skills, decision making, anything that could be a barrier to their personal progress and to their overall wellness. And so the PRS staff members are really effective at coaching and at helping to identify specific goals and ways to build on a person's strengths so that they can kind of succeed in achieving those goals. So that's kind of the PRS side. And it's actually really great for folks, and it's geared towards folks with serious mental illness. But as Marcella described in her discussion of the Crosswalk, PRS is not an eligible service for people whose primary diagnosis is substance use disorder. So that's a whole area of a whole population within Project Home who is not able to access these really valuable services. And that's kind of why Project Home really is very excited about this collaborative, because we really feel that this is a PRS-like service is really needed for folks whose primary diagnosis is substance use. And then I mentioned the Federally Qualified Health Center. I'm happy, I'm not going to go into all the details about that because it's a very long and involved process. I'm happy to share our experience with any of you on the line that might be interested in pursuing this. Just tread carefully. It was a very painful process, and it was a very involved process, but definitely once we got to the other side, we're really happy that we did it, but I can help anyone out there kind of avoid certain pitfalls. We have lots and lots of lessons learned to share about that. Another piece of this, I guess I want to add another dimension to the idea of all of us advocating for Medicaid supportive housing, is that we would be addressing the Medicaid system's desire for better quality of care. So I think if quality is something that the healthcare world, healthcare industry talks about a lot, and they talk about it being timely, efficient, equitable, effective, safe, and person-centered. And I can think of no other better intervention than supportive housing that kind of fulfills all those dimensions of quality. So I think if we can kind of use that language with the healthcare system and leaders in the healthcare system, payers, things like that, we can convince them that this that housing does really fulfill all these dimensions of quality. A little bit about, oops, I'm advancing the wrong set of slides. Here we go. That's what I was just talking about. Sorry about that. Okay. And moving on, a little bit about the quality healthcare. So we look, again, from like the healthcare provider's perspective, we also judge quality in terms of how the patient views the healthcare service, how the provider views it, and how the payer views it. And the payer, in this case, the state Medicaid agency, is sort of the payer that we need to kind of, or the perspective that we need to pay attention to. And what they're really interested in is making sure that the Medicaid dollars are purchasing value and that they're achieving what's called the triple aim. Again, if you're not in the healthcare world and you're more in the housing world, this might not be a familiar term, but this is something that's ubiquitous in the healthcare world. This idea of the triple aim, which is to improve health, give patients a better experience of healthcare and lower cost. So the more that we can kind of band together and advance all these ideas that are presented in the crosswalk to saying that this will eventually achieve the triple aim will only be to our benefit. So we're talking, just to kind of wrap up, so the crosswalk hopefully will result in the idea of the state pursuing a CMS waiver, which Marcella already went into. And also kind of like a little bit in the background is that the Department of Health and Human Services in Pennsylvania is looking towards value-based purchasing, and potentially supportive housing can increase the value of their Medicaid dollars in purchasing better care, because we're helping people who would need supportive housing to kind of receive care in the appropriate settings. So not so much in the crisis or emergency settings, but trying to receive care in outpatient or primary care settings, which is less expensive, actually better for them, and also is a better way and a more efficient way to spend the Medicaid dollars. So sorry if that's a little bit of a whirlwind, but I'm happy to take questions at the end, or you can type it in the chat box there. Thanks.
So we've had, good afternoon everyone, this is Patrick again with the Pennsylvania Health Access Network. So I know that I'm the person standing in the way of questions, so I really wanted to just summarize things really briefly. We have a solid series of recommendations, and in the follow-up to this webinar you'll receive an easy to digest executive summary. It is 1 page long with 2 sentences on the second page. You couldn't make it all fit, but it's a very brief summary of the crosswalk. There's also a full version of the full text of the crosswalk is available online, along with the executive summary on housingishealth.org. What do we need right now? We've got these recommendations. Marcella and her team have spent a lot of time sorry, it looks like the slides had advanced back. So Marcella and her team had spent a lot of time putting these together. It's solidly based research in the Medicaid state plan, and so we need organizations to endorse these recommendations. If you are at that level in your organization where you're an executive director or COO or someone that has that capacity, we would welcome you to go to the website housingishealth.org, complete your information, and then our team will follow up just to make sure that you want to publicly endorse these recommendations. If you're not at that level, we really need you kind of sharing these recommendations with decision makers and helping kind of raise awareness that this movement is happening, and this is certainly possible within Pennsylvania. Monica already mentioned this, but the state, many of you may have been on the Housing Alliance's webinar last week on the 5-year housing strategy with Ben Loudermilk and Jonathan McVeigh. The state is certainly looking at this, and so our goal with getting organizations to sign on these recommendations is letting the state know that there's a broad base of individuals that support the state taking this action in a timely manner and expanding supportive housing services for more individuals. Another thing that as commonly comes up is the issue of cost. Marcella at the end of the presentation talked about any cost savings being reinvested in quality supportive housing. And so what we're working on right now is a business case that would actually examine the finances that go behind funding supportive housing services through the state Medicaid program and what the state could potentially realize by funding those services. So that's going to be available in August. We are, in the meantime, looking for stories from both the consumer perspective and the provider perspective about the benefits of supportive housing services. Monica talked a lot about different individuals that either benefited or could have benefited from supportive housing. So we need, the Monicas of the world to kind of stand up, as well as, those of you that are directly in contact with consumers that would benefit from these services to help kind of connect this campaign with those individual stories. And there's actually, again, on housingishealth.org, there's a story forum where you can kind of submit your contact information and someone from our team can reach out. All of this is building towards a big event that we have September 26th in Harrisburg, where we will be highlighting all of this in a very public way in the Capitol Rotunda, educating lawmakers and state officials about the benefits of supportive housing services, and really calling on them to take the next step in making sure that Pennsylvania acts on these recommendations. So more details can certainly come if you sign on to the recommendations, or if you express an interest in our campaign, we'll be sharing more information about that. But that's really where we want to take the recommendations next. I should mention, in addition to the follow-up with the executive summary of the crosswalk, we do have 2 calls a month for the campaign where we can kind of talk about some of these logistical details. I'll make sure that Joyce has those, but the next one is coming up almost a week from today at 1 o'clock on Wednesday, August the 3rd. And it's basically the first and the third Wednesdays of the month at 1 o'clock, and we'll send out the call-out information. But that would be August 3rd, August 17th, September 7th, and September 21st are the dates for those calls prior to our event on the 26th. So we would welcome you if you have a particular interest in this. Please feel free to join in those calls so that we can figure out how to involve you either on the 26th or in other ways in the activities of this campaign. So Joyce and the Housing Alliance, we want to thank you guys for being able to present these recommendations to the group. And with that, Joyce, I turn it back to you to open it up to questions.
Great, thank you so much. For folks, I'm not going to unmute the line, but if people have a question or a comment for the panelists today, do *7. And we do have a question from a participant woman who's asking, are you only looking for organizations to sign the recommendations, or may individuals also sign?
It's a great question. So if you go to housingishealth.org, there's the prominently featured there is the spot for organizations to sign on. However, if we certainly welcome individuals to sign on as well and keep up to date on the campaign activities. So right above that form where organizations can sign on, there's a little link that says if you're an individual, click here. And, we have a petition that will be accompanying the organizational sign-on. So we welcome both organizations and individuals. And both can be done at housingishealth.org.
Thank you. Do we have other questions? Again, on your phone, do *7.
Hi, this is Roy Diamond. I have a question.
Go ahead, Roy.
I guess it's a multi-part question. The first is, have you projected how much money you want the state legislature to appropriate in order to support what size of waiver? And my second question is, have you assessed to what extent the homeless population intersects with the DD or ID population? And if so, if you think those are significant numbers, are you asking for increase in waiver-funded services for those populations as well?
So, Roy, this is a great question. I'll give you a brief 2-second answer, and then, Marcella, if you have other things to kind of add, feel free to do so. But so as far as the projections, we will, in our business case, take an initial stab at carving out a population, specifically those that are chronically homeless, that could benefit from supportive housing services. But it's really up to the state to kind of look at, overall what the populations are and kind of work with us to kind of, again, we want to see as many individuals cover the services as possible. But it is a very delicate act, and it's something that the State Department of Human Services is taking very seriously. They, my second part to your question, when you're talking about DD and ID, is that so our crosswalk has specifically focused in on populations that would interface with the Office of Mental Health and Substance Abuse Services, OMSA, within the Department of Human Services. The department itself is doing a crosswalk that spans all of its various offices. So we focus in on OMSAS, but they're going to be looking at OLTL and other offices, that interface with OMAP to do a more comprehensive crosswalk, and out of that, they would have a better answer as to the overlap between those that would qualify for supportive services under our proposal versus, where the overlap is for DD and ID.
Gotcha. Thank you. Just a corollary on that, given how conservative this legislature is, have you made an assessment as to the likelihood of success?
So this, supportive housing services is an evidence-based practice that really, highlights I think even in a conservative climate, people are concerned about dollars and cents, and the evidence is clearly there to show that supportive housing services saves the state money,
Gotcha.
in the long term, especially when you talk about higher cost utilization. And so, Marcella, feel free to, you guys have got other experiences with this across the country, but we know that, states that take this approach and do this model have been able to see multiple benefits that they can quantify. So, Marcella, do you have other things to add there?
Yeah, no, absolutely. There's a couple of different options here. There's folks who are using supported housing. I know I'm working with Illinois at this point and Texas in regard to some of their trying to help folks with intellectual disabilities get out of state-supported institutions and into supportive housing, and how do you build the capacity with the right services and the right supports within each state Medicaid plan. Roy, I heard you asking about the waivers as well. I don't know what the latest numbers are on, how many ID folks are waiting for sort of their name to come up in the waiver process.
It's a long waiting list.
It's a thousands. I've never heard it less than, not at least a 4-digit number. So a lot of times what happens there is that the waiver services do fund supported housing. We might not think of it that way because it's person by person as opposed to project by project the way, Project Home or one of the developments you work with there. So there's a lot of opportunities. We focused here in particularly on folks with mental health and substance use challenges. One, to highlight that there are a lot of opportunities and sort of the way things are for folks with SMI, but to try to highlight some of the other populations. With the ID population, and this would be, I'd want folks with, on the ground in the state to weigh in on this one. Does it make more sense to do more supportive services through through the MCOs, what Pennsylvania we call the BIMCOs, or do we want to expand the waivers? And then, of course, you raise the importance of, what's the bottom line number both for the state and then in any dialogue that we have to have with the feds and the Center for Medicare and Medicaid Services, the CMS.
I just know anecdotally that when the Office of Autism Services started within DHS several years ago, one of its first efforts was to address homeless individuals who were ID or DD. And I only know the anecdotal, tales, so I don't know what the numbers ended up being. And I'm curious as to whether Project Home, when it diagnoses and assesses its homeless population that it serves, to what extent it comes across a DD or ID person, or whether that's largely not the case.
It's I would say anecdotally it's largely not the case. This is Monica, but we have a psychiatric nurse practitioner that's kind of able to tease that out and to do that assessment. Sometimes it's really hard even to determine to what degree there's the past brain trauma has resulted, in a lot of the symptoms or the presentation of the person. So it's honestly kind of hard to tease out without maybe other, formal records and things like that from hospitalizations.
Gotcha.
Yeah, but that's a good point.
Monica, if you don't mind me jumping in and speaking for outreach for a minute.
Sure, yeah.
We would see it we do see it sometimes on the outreach side, not that frequently, but, even just once is just an absolute tragedy. We often find it a lot that when we do get people in to supportive housing, often on the Housing First programs through Horizon Health Pathways, there's either some history of being connected to that system or significant intellectual disabilities that I don't want to say it's more likely folks in the borderline range, et cetera. I mean, if you're going to survive on the streets for more than a minute or two,
right, you need some skills.
Exactly, you need some skills. So we see a lot of that undiagnosed, and then when people get stable and can get the testing and the right services and things like that, then you often see it, particularly often in autism. We've seen some really, really challenging folks who, quote, wouldn't accept services for a long time until we, worked with them with a housing first model, and often it was autism. They couldn't make the connections. The social challenges that folks with autism have a hard time with was just really hard for them to manage shelter or, any of the other immediate services.
Great.
So not often, but really difficult and tragic when it happens.
Thanks.
Well, thank you to everybody that replied to the question. Appreciate it.
Thanks, Roy. Do we have other questions or comments from the group? Again, it's *7 to unmute. It's a quiet group. Hope everyone's staying cool. Just open it up again. Any other questions? We can end a little early. *7. Well, the Housing Alliance will continue to work with this group, and for us, it's about getting more opportunities out to people in our community and part of our network. So I just want to thank everyone on the phone for participating and also for our presenters. Thank you so much.
Joyce, thank you.
Thanks to the Housing Alliance for organizing.
Thank you.
Bye-bye.